So, good day. I hope you are having a nice day. So, let's begin with the very first file of obstetrics and gynecology, and we are going to divide it into three parts. So, in the very first question, we have a 52-year-old woman suffering from obesity. Complains of bloody discharge from sexual parts during 4 days. You're going to see a lot of discharges in obstetrics and gynecology. Last number menses were 2 years ago, so this is a woman in menopause. But right now, biopsy revealed that the woman is having adenomatous hyperplasia. What reason could have accounted for the development of this disease? See, in this particular patient, they are telling us that a woman in menopause and obese. So obesity is a predisposing factor to a woman to end up developing estrogenemia, high level of estrogen, and that is like excessive transformation of pre-androgens from adipose tissue. And obesity is a major risk factor in such patients, and you know that the growth of the endometrium is directly proportional to the amount of estrogen in the woman. So a 40-year-old woman complains of colicky pains in the lower part of abdomen, and you see abundant bloody discharge from the genital tract. So this is another discharge, but a completely different history from what we've just read. And if you look further, it's clear that the patient had been having polymenorrhea, and the fibromatous node that was revealed by manual investigation is actually on a thin stem. Once you have a fibromatous node that is on a thin stem, in most questions, in almost any question, the best thing to do in that condition is the untwisting of the node and having it out. So this is requiring a surgery. So even though the size is 3 centimeters, but the fact that it's on a thin stem, it's require untwisting of a paw node. We have a 40-year-old woman complains of yellow colored discharges from the vagina, another discharge from the vagina. So you'll notice that biomedical examination, no particular changes. Smear test. So patient is having trichomoniasis. Trichomoniasis, actually what you need, that you just need to treat is a specific treatment. Treat it specifically, but we cannot just go for specific treatment. Notice that a functional test was done. And it gave us a negative. This is supposed to be negative iodine probing or Lugol probing. So we have negative iodine probing. In normal cells, we are supposed to have a positive reaction to iodine. It's supposed to turn like blue, black, like dark. So, but here it's negative, and when it's negative, you are thinking of that the presence, we are definitely having like abnormal cells beginning to develop in that particular area. So the best thing is you treat the copitis as a result of Trichomonas infection together with a biopsy. Why are you doing biopsy? Because of the negative. If this were to be positive, our answer will have been special treatment of Trichomonas copitis. 32-year-old woman consulted a gynecologist about having abundant long menses within 3 months. So by manual investigation, the body of uterus is enlarged according to about 12 weeks of pregnancy. So you can read further histological tests of uterus, adenocystis, hyperplasia of endometrium. Actually, when they give us such a condition in which we have a mass in the uterus and it's up to 12 weeks, so 12 weeks and above is one of the indication to a surgical treatment. Please, let's take note of that. So here, don't think of hormone and anything. When the size is up to 12 weeks, is one of the indications for surgery. A woman complains of having slight dark bloody discharges and mild pains in the lower part of abdomen for several days, last menses were 7 weeks ago. You see, when they are telling you that they are telling you about last menses 7 weeks ago, 4 weeks ago, or whenever, they are trying to point your attention to the fact that it's likely that this patient is pregnant. So the pregnancy test is positive. By manual investigation, the body of uterus is about 5 to 6 weeks of pregnancy, and in the left appendage is a retort formation, some by 5 large mobile penis. What examination is necessary for detection of fetus localization? So the cause of the discharge, and together with the lower abdominal pain, you are thinking of probably an ectopic pregnancy. And how do you try to detect the location of the fetus? Is by doing an ultrasound. The only other option that could actually confuse you in this condition is hysteroscopy, but you are not yet sure that is directly at the level of the appendages or the fallopian tube. So it's best to do an ultrasound. You can check both the uterus and the appendages. A woman was hospitalized with full-term pregnancy. Examination, notice like full-term pregnancy. Examination, the uterus is tender, abdomen is tense, and cardiac tones of fetus are not auscultated. What is the most probable complication of this particular pregnancy? Please take note of this. This will help us to distinguish between placenta abruptio and placenta previa. You know, in placenta previa we have abnormal location of the placenta, usually closer to the internal os. In placenta abruptio we have early detachment of the placenta. But when they are telling you about an eventful fetal cardiac monitoring result, or not very favorable, or could not auscultate it, and in a full-term patient in third trimester, you can start thinking of placenta abruption. It is, if you are to be acute hypoxia of a fetus, they will give you more details about that fetus. But the focus here is about the woman. See, the abdomen of the woman is tense and the uterus is tender. This is because there have been a placenta abruption. This patient also is going to be bleeding. Alright, so here we have acute hypoxia of fetus. You can notice that in the first period of physiological labor, amniotic fluid came off. Contraction lasted 35 for every 45 minutes. Heartbeat of fetus was 100. This is so low in a fetus. Having this is so low in a fetus, and one of the major things that can be causing is a child that is having hypoxia. So this acute hypoxia. So unlike placenta abruptio, in which we had, it could not even auscultate, you could not hear the cardiac sound, and the information was more about the uterus. A pregnant woman in her 40th week of pregnancy undergoes obstetric examination. The cervix of uterus is underdeveloped. Notice 40th week. The oxytocin test is negative. At 2 weeks, please take note of this question. They are not telling you right now that at the 40th week, they are trying to give you a history of this woman. So at 32 weeks, at your blood pressure was 140/90, proteinuria 1 gram. You see, at this level in which the blood pressure is elevated 32 weeks ago, they expect that definitely this patient is being taken care of. Choose the most correct statistics. Actually, in this particular patient, since we are having oxytocin tests being negative, we just need to stimulate labor with oxytocin and prepare this patient for delivery. So it's not cesarean. There's no indication for cesarean in this particular patient. Alright. What gestational age gives the most accurate estimation of weeks of pregnancy by uterine size? The straight for actually is less than 12 weeks of gestational age. That's when it's more accurate to know the age by just measuring the size of the uterus. Alright, we have a 26-year-old woman who had the second labor within the last 2 years with oxytocin application. Weight of the child is 4,080 grams. After the placenta birth, there was massive bleeding. leading to signs of hemorrhagic shock. Despite injection of contractive agents, good contraction of uterus was absent and bleeding proceeds. Choose the most probable cause of bleeding. You see, one of the most probable cause of bleeding in after delivery in a postpartum patient is uterine atony of the uterus. And we could see here that the patient had been given contractile agents yet without any results. So this is atony of the uterus. A woman is admitted to maternity home with discontinued labor activity and slight bloody discharges from the vagina. The condition is severe, the skin is pale, consciousness is confused, and patient is in shock. Patient is in shock. Heartbeat of the fetus is not heard. There was cesarean section a year ago. You see, we've seen about different causes now. Bleeding in the postpartum period, we spoke about atony of the uterus as the most common cause. Where you're having bleeding in the third trimester, especially towards the end of the third trimester, you are thinking of placenta abruption, in which they write as early separation of placenta. When you have also bleeding, and the bleeding is majorly maybe early in the first trimester or any period after the 24th week, you are thinking of placenta previa as well. Placenta previa is the same as placenta presentation in this question. So whenever you see placenta presentation, know that they are talking about placenta previa. So blood pressure is 80/40 in this patient in a woman that had cesarean section a year ago. This is a very risk factor to a patient that could actually have the rupture of the uterus in another pregnancy. So this is a patient with uterine rupture, and that is this term here is hysterorhexis. Hysterorhexis. So it's not this because of this history of cesarean section a year ago. On the first day after labor, a woman had the rise of temperature to 39 degrees after labor, first day. Rupture of membrane took place 36 hours before labor. So this is early discharge. It is premature rupture of membrane. Examination, and that could predispose a woman to infection. Examination of the bacterial flora of cervix of uterus revealed hematocateric streptococcus of group A. You can notice all these discharges are bloody and admission of pus. So you are thinking already of infection. The question is indicating that. Specify the most probable postnatal complication, and this infection most of the time is going to result in the inflammation of both the endometrium and the myometrium, and that together is referred to as the metroendometritis. Metroendometritis. If it is infectious complication of the urinary system, the focus is going to be on the urinary organs from the question. So please, none of this. This question, we have a repetition here. All right. A woman of a high risk group, you see chronic pyelonephritis in anamnesis, had vaginal delivery. The day after labor, she complained of fever and loin pains, frequent urethania. So still thinking of pyelonephritis. Specify the most probable complication. So in this patient, it's simply infectious contamination of the urinary system. Yes, it's straightforward. Now let's pay close attention to this question. It will help us distinguish it from a patient that is having tumor of the master gland or pituitary gland. 13 months after the first labor, a 24-year-old patient complained of amenorrhea. You see, after first labor, let us say after delivery, 13 months after, patients complained of amenorrhea, absence of menstruation. Pregnancy ended in caesarean section because of premature detachment of normally positioned placenta, so placenta abrupta, which resulted in blood loss at the rate of 2,000 mils owing to disturbance of blood clotting. the normal blood loss in a pregnant woman or during the delivery is supposed to be 0.5% of the total weight of the woman. So if a woman, for example, a pregnant woman is 60 kg, the amount of blood loss during pregnancy is supposed to be 0.5% of that 60 kg, which is 300 mils. Another way to calculate it is simply to add 0 to the front of the weight, that would be 600, and simply divide it by 2, that will give us 300. But when a woman has bled so much, you see we're having 2000 ml, what it's going to cause is going to cause pituitary infarction. There's going to be reduction in blood flow to the pituitary gland, and patient is going to develop what is called the Sheehan syndrome. Sheehan syndrome. For you to put diagnosis of Sheehan syndrome, which is going to result in decreased level of hormonal production, you need to estimate the level of gonadotropin hormone, definitely to be very low. That is why we have amenorrhea. When we get to patient prolactinemia, we will differentiate it from this condition. So we have a repetition here. Okay, we have a woman of 24 years, about earlier normal menstruation, cycles became irregular according to test of function diagnostics, and this cycle is anovulatory, without ovulation. The content of prolactin in blood is boosted. There's increased level of prolactin, and the pituitary gland produces prolactin. So when you have a high level of prolactin here, you are thinking that maybe there is a cancerous process in the pituitary gland. One of the only thing that can help us to prove that is CT of the head, not determination of level of gonadotropin, because prolactin is not a gonadotropin. So you are not going to get any answer from there. So you do CT of the head to exclude or confirm for that there's a pituitary tumor. A woman in her 39th week of pregnancy, the second labor, has regular birth activity. Uterine contraction takes place every 3 minutes, which is good. What criteria describe the beginning of second labor the most precisely? Though for me, I believe that this question they should have just removed most precisely from it, because the correct answer is cervical dilatation not less than 4 centimeters. Beginning of second labor is the end of cervical dilatation to delivery of the fetus. So they are using 4 centimeters. They should have just taken it to 10 centimeters so that it can be most precisely. But however, this is the correct answer in this case. This is the correct answer in this case. This is first stage of labor. And this could also confuse, because you can have uterine contraction over 30 seconds at interval of 4-5 minutes in normal labor. So what is the answer? A 20-year-old woman is having time labor continuing for 4 hours. Woman has continuous labor for 4 hours. Light amniotic fluid off. You see, when you read all this presentation, apart from the fact that these patients have been in labor for about 4 hours, other things mentioned there, they are relatively okay, normal, but there's need to administer the patient glucose, calcium, and vitamins. So for what purpose? So they're asking for what purpose? Now, since you know that the patient has been in labor for about 4 hours, you are definitely thinking that this patient might be getting weak physically and even by the body physiology of the woman. So you are thinking of weakness of labor activity. But is it prophylaxis or treatment? Is it prophylaxis or treatment? The fact is, there's nothing in the question showing us already that patient is having weak labor. So since we don't have that, we can only give prophylaxis. We can give it only prophylactically. So this is for prophylaxis. Alright, 25-year-old primipara was hospitalized with complaints about discharge of amniotic waters. The uterus is tonic on palpation. Position of fetus longitudinal, it is pressed with the head to pelvic, and the palpation of the fetus rhythmical, is normal, good. Internal examination, cervix of fetus is 2.5 centimeter long, then external house is closed, light amniotic water out of it. Because point a correct component of this diagnosis. The fact is, this patient, since the uterus is tonic on palpation, this patient is beginning to initiate labor. So this is antenatal discharge of amniotic waters. If it is early discharge of amniotic waters, it's going to be, they tell us, several hours or maybe a day or whatever before signs of first stage of labor. But this is around the period of labor. So this antenatal discharge of amniotic waters. A 34-year-old woman in her 29th week of pregnancy, that is her fourth labor to come, was admitted to the obstetric department with complaints of sudden and painful bloody discharges from vagina that appeared 2 hours ago. 2 hours ago, see, 29th week of pregnancy. The discharges are profuse and contain grooms. This is like clotted blood. Cardiac function of the fetus is rhythmic, and you can see that this is pretty good, 150 strokes in a minute. Ultrasound or ultrasound is normal. What is the provisional diagnosis in this patient? If it is DIC, they are going to tell us about other things that could have led to this condition, such as infection, or there's something in the, or we have abortion or something, but that's not the condition here. But the right answer in this particular patient is that we are having abnormal placenta presentation. Notice I said earlier that they are telling us about bleeding in maybe in early third trimester or late second trimester. One of the reasons could be placenta previa. Placenta previa in this is placenta presentation. So that's it. The detachment of normally located this placenta abruptio. We also have bleeding as in previous question, but it didn't tell us about this clotted blood, and the cardiac investigation of the child is really going to be poor. 29-year-old patient underwent surgical treatment because of the benign serous epithelial tumor of an ovary. See, if the patient had undergone surgical treatments of the ovary, so patient is going to be having need for hormones. You know that the ovary produces two major hormones, very important: progesterone, estrogen. The postoperative period has elapsed without complications. What is necessary to prescribe for the rehabilitation period? You want to give hormones, so hormone therapy and fertility enzymes. 34-year-old woman with 10-week pregnancy. The second pregnancy, as a gynecologist was consulted to make record in the patient's chart. There was hydramnion previous pregnancy. So in a Gravi 2 para 1 patient, see, the birth weight of the child was up to 4,000. What tests are next tests we first of all? So when a patient is having history of polyhydramnios or hydramnion, simply as it's written, you are thinking one of the risk factors that could have led to that is diabetes. So you want to check for you want to do a glucose tolerance test in this patient. 26-year-old woman complains of sudden pain in the bottom of abdomen irradiating to the anus, nausea, giddiness is dizziness, bloody dark discharges from sexual tract for 1 week, delay of menses for 4 weeks. Again, they are telling us delay of menses that this patient is likely pregnant. Signs of peritoneum irritation are positive. Something is leaking to the peritoneum. Bimanual examination borders of the uterus and its appendages are not determined because of sharp painfulness. The diverticulum, you see, with all these things, you are thinking already that this is no longer like a normal pregnancy. Since the patient is pregnant based on delay of menses for about a month, you are thinking of an ectopic pregnancy. So when they're telling you about bloody discharge in a patient that is just pregnant, and you are saying that the abdomen is painful and so on, you think of tubal pregnancy. Differential diagnosis of this particular patient could simply be abortion, but they are not going to be giving us all this history that is pointing our attention to the appendage. At the gynecological department, there is a patient of 32 years with the diagnosis of acute batholinesis. We have one on the right, one on the left. Body temperature 38.2, and the sign of fluctuation. So you are thinking already of an abscess, or you are having fluctuations and you are thinking of an abscess. What is the most correct tactics of this doctor? You have an abscess, you want to do surgical dissection of that abscess, then you drain the abscess. One of the reasons why abscesses need to be drained is that the capsule prevents antibiotics from going into the abscess cavity, and that abscess cavity itself, if you cannot reach there, it means that you can't keep the organisms. So, but after doing that, you still need to give an antibiotics. So, surgical dissecting, draining of abscess of the gland, and antibiotics. We have a primigravida woman here, like complaints of headache, nausea, like signs of severe preeclampsia. Face is hydropic. There's short fibrillary twitching of blepharones, moses of face, and one of the things you want to do in this patient is even to try to prevent eclampsia. So 37-38 weeks of pregnancy. What medication should be administered? In this particular patient, we are going to give droperidol. And droperidol is like is an anti-dopaminergic drug. If they combine together with fentanyl, is a neuroleptic analgesia. It's going to calm the patient down, and one of the side effects is that it can even cause hypotension, which means that this drug can also help to lower the blood pressure. Other drugs, say like papaverine and the chloride, this is a spasmolytic. Hexanium, pentanium, these are drugs that can block the ganglion and also help to reduce the blood pressure. But the best answer here is droperidol. It's going to calm the patient down or make the patient to go like tranquilizer effects, and also can reduce the blood pressure. Such patients will not proceed to eclampsia. Also, another drug that can help us to in such conditions, magnesium. An onset of severe preeclampsia at 16 weeks gestation might be caused by. Now we know that preeclampsia usually begins at 20 weeks greater, but here we are having severe preeclampsia at 16 weeks. One of the first thing you think of is hydatidiform mole. In hydatidiform mole, we have fertilization, and the fetus, that the product of conception that is supposed to develop into a fetus is just developing into like a benign mass rather than a fetus. So it's one of the major, it's one thing that can cause severe preeclampsia at such early stage. Alright, a woman had the rise of temperature up to 39 degrees on the first day after labor. The rupture of membranes took place 36 hours. We've done this question, this is a repetition, menstrual-adenitis. Again, this is a patient with Sheehan syndrome, SHEEHAN, that is the anterior pituitary necrosis or infarction due to a postpartum hemorrhage. Again, we said that we have to determine the level of gonadotropins. Alright. This is also a repetition in a patient with hydramnion. We said risk factor, diabetes mellitus. We want to do test of glucose clearance tests. 10-year-old boy was ill with angina 2 weeks ago. Has complaints of joint pain and stiffness of his left knee and right elbow. This is, I don't know why we're having this question that ups and down. There was fever, 30, and ankle dysfunction, enlargement of cardiac dullness. See, a child that had angina 2 weeks ago, and now is having rheumatological disorder. So it's rheumatic fever. With talked about this in internal medicine. So I'm going to stop for now and continue